I thought it would be nice to do some video posts instead of just written posts about key aspects of management of lymphoma. In this case, understanding the treatment of diffuse large B-cell lymphoma. One of my motivations is I want to highlight the important things to understand about the treatment, because I find that many patients, especially the more well-read ones, tend to linger a lot over things that are not really key, not along the, let's call it the critical pathway towards cure. And I wanted you to understand really the big issues about treatment. And the objective of the post is to look at treatment in the relapse setting, but I think it's also good to first understand what goes in the frontline setting, and from there to go to the relapse setting. So these are some of my disclosures. And let's start by understanding what to anticipate from treatment in the frontline setting. So about 70 to 80% of patients that are treated in the first line setting, right, can anticipate cure just with this treatment. And these treatments are, are based on a backbone of a chemotherapy regimen called RCHOP. Sometimes something will be added. Sometimes they will modify to dose-adjusted epoch, but the results are ultimately the same. And how do you read these plots that you see, the graphics that you see on the screen? We are basically on the x-axis, we are looking at time from the first start of chemotherapy. And on the y-axis, we are looking at the percentage of patients who are without evidence of progression or relapse of their disease and that they are alive, right? So on day one, 100% of the patients are alive and the disease has not grown. And as time goes by, we have patients who start to drop because the disease progresses and they need other therapies. Note that if a patient dies for whatever reason, the line will also drop because we don't know what's the status of the lymphoma at that time. And what you can see here that, RCHOP or polar R-CHOP, around the 6 months mark, most of the dropping that is going to be happening, right, already happens around the 6 to 8 months mark. And what is this 6 to 8 months mark? That's basically the time that we finish the first 6 cycles of chemotherapy and we do the end of treatment evaluation. Then, there are going to be a few more drops, maybe about 10% more drops that happen by 2 years from start of treatment, which is 1.5 years from the end of treatment, right? And in some studies it's only by the first year, in some studies it's a little bit longer, but ultimately it all looks more or less the same, right? So we have most of the failures are actually not relapses, they are disease that is still present at the end of treatment, so a primary refractory disease, and about 1/3 or 1/4 of the events are actually relapses that happen later, mostly within the year, 1.5 years from the end of therapy. Beyond the first 2 years, relapses are quite few. So if a patient experiences a relapse, this is the NCCN guideline. So this base gives you what we call the probable oncologist behavior. What is the agreed mean or average that should, one size fits all. And we are dividing patients into those who had a late relapse, so beyond 12 months from the end of therapy or 1.5 years from starting treatment. These represents about 25% to 1/3 of all patients, and those who have a primary refractory disease, meaning that they were more resistant to R-CHOP, and they present in the first 12 months. In terms of, and we say both of these groups together, they represent roughly 30% of patients who were treated with R-CHOP or R-CHOP-like chemotherapy. And what are the treatment options that we have for these 30% of the patients? We have genetically engineered T cells. So these are immune cells that are engineered and cultured to fight the lymphoma. This gets long-term remission, which we think are cure for roughly 40% of the patients who have a refractory disease. We have the possibility of trying to give more chemotherapy, so some type of a second line treatment, a combination of chemotherapies. And if the patient is sensitive to that chemotherapy, meaning they achieve a complete response to that chemotherapy, we go to what we call an autologous stem cell transplant, which is basically giving high doses of chemotherapy while preserving the bone marrow in the fridge so we can infuse it back. This cures around 20 to 25% of the patients. And then we have several new agents on clinical trials, the most interesting of which are bispecific or trispecific T cell engagers, which we think are going to lead to a long-term remission or cure in about 40 to 45%, very similar to what we see with CAR T cells. And then we have other agents that are efficacious, but not to the 40-45% grade, which are antibodies that come together with chemotherapy, like polatuzumab and loncastuximab, or novel antibodies that we give together with drugs that are meant to activate the immune system, like lenalidomide. And there are other novel agents in the pipeline to be evaluated. So, and I think what's the take-home message from here is that really, if you look at diffuse large B-cell lymphoma, you start with RCHOP, 70 to 80% will be sensitive and cured. 20 to 30% are just not sensitive to chemotherapy, and unfortunately we just don't know them up front. We just don't know upfront who are those, right? In an ideal world, we could say you're sensitive to chemotherapy, maybe let's even give you less, and you're going to be completely insensitive to chemotherapy, so let's just not bother with chemotherapy or give you some type of a combination. And, a few of the patients are somewhere in between, so, let's give you some other type of chemotherapy, right? But these 20 to 30% are not doomed, right? They have excellent treatments. The only question is how do you sequence them, right? Almost half of them will be salvaged with one type of treatment. Almost another half will be salvaged with another type of treatment. Some can be salvaged with higher doses of chemotherapy, and many can be salvaged with these novel agents. And this is before we even start talking about clinical trials. So it's very important when you step into the treatment that you know what's the course, and you don't get discouraged if you are not among those patients who are sensitive to chemotherapy. It's just a different type of disease, and there is a pathway towards cure. And the job of the lymphoma oncologist is really to minimize unnecessary chemotherapy treatment and then sequence these treatments in an order that makes sense for the particular patients. So what happens if a patient finishes frontline chemotherapy and is found to be refractory, resistant to RCHOP, or very often the disease will go completely away, so a patient will get a complete response, but within a few months suddenly the disease will come back. So what happens with these patients? So again, we are seeing these plots. This is the ZUMA-7 study. It evaluated CAR T cells against the standard of care at the time, which was give some chemotherapy, let's say R-ICE or R-DHAX or R-GEMOX, give some chemotherapy. If the patient gets to a complete response, and at the time they were also using partial response, but it's inappropriate for DLBCL. If a patient really proves to be extremely sensitive to this chemotherapy, then go to give high-dose chemo while preserving the stem cells, what we call autologous stem cell transplant. And the study demonstrated that CAR T cells were superior, and we will see that in a second. But I think the more important take-home message is that around 20%, and it depends on how you define it, it's between 20 and 30% of the patients who went down the standard of care route actually got to a long remission, right? So we are here 2 years and 3 years almost out, and these patients have not relapsed and they are likely cured. So it should not be forsaken, this route. It should be, you should remember that it has an activity. On the other hand, when we gave CAR T up front, around 40 to 45% of the patients will have long-term remission and are likely cured. But this is not the only objective. Around 85% of the patients will have some type of a response. 65% will have a complete remission. So 85% of the patients will reduce the amount of disease considerably. So even if they don't have cure, it's still good, right? Because we have bought ourselves time towards other treatments that we have, like we saw in the previous slide. Now, what are the side effects of CAR T? Why don't we want to give it to everyone, or why do we have a contemplation about it? Well, CAR Ts cause these immune events, and when we look at side effects, we are really interested in those that are grade 3 or higher. So these are events that land patients in the hospitals. Grade 4 can sometimes land a patient in the ICU. And you could see that around 6 to 10% have what we call a cytokine release syndrome with this particular drug. And cytokine release syndrome, if you want to imagine, is like having a very hard flu. So grade 3, 4 is a serious flu. We know how to treat these, but some of these patients can end up in the ICU. It's usually transient and it goes away. And 21% have neurological events, which are confusion, aphasia, difficulty speaking, encephalopathy, which is another type of confusion, delirium, which is another type of confusion. Grade 3 is going to be serious. So someone may be comatose or completely confused, look like an Alzheimer's disease patient. And these two tend to be transient and go away, but it can be stressful, and in some cases it can be prolonged. And we do see some confusion or like a light dementia that develops after the CAR T therapy. It is also transient, but it can be very disturbing. The second thing that I want to show you is 30% of the patients achieved a complete remission to chemotherapy, and another 20% had partial remission. So if you just get second-line chemotherapy, you have a 50% chance of reducing your disease burden extensively, let's say, okay? Now, you can see that there was not much of a difference in terms of the long-term outcome of those patients who responded to chemotherapy and those patients who responded to CAR T-cell therapy. And if we were to look just at the greens, so just at the patients who achieved the complete remission, we would see that the line is somewhere around here for both treatments. Meaning that if you get to a complete remission by chemo or by CAR T, around two-thirds to 75% of the patients can actually expect a long-term remission and possibly cure. So again, going back to this issue that in some scenarios, you would give a second-line chemotherapy like RIs, you would give it for 2 cycles, you would do a PET-CT, and only if the patient is in CR, they will go down the stem cell route, and if they are not in CR, they can go down the CAR T route. So meaning to say that, in certain scenarios, chemotherapy still has a role in these patient population, and definitely in patients who relapse over 12 months from the end of therapy where CAR T-cell is not approved. But again, this is a different agent. Again, we see cytokine release syndrome of grade 3 in 1%, so it's a much milder agent. And we see these severe neurological event in about 4%, so slightly better than what we saw in the previous agent. So what's the alternative to doing CAR T-cell or chemotherapy? The third approach we talked about is the approach using bispecific, and now there are also trispecific antibodies. What's the trick in these treatments? So this is the protein, the bispecific antibody. on one side, it connects to CD20, which is also the target of rituximab. So it connects to the lymphoma cell. On the other side, however, it connects to the T cells, and these are the cells of the immune system that are supposed to fight lymphoma. These are also the cells that we make CAR T of. And the motivation to create these treatments was, if you consider that, if you take these CAR T cells and you genetically engineer them in the lab to have a CD19 receptor, which is another receptor that exists on the B cell, and you culture them and you give millions and millions and millions of these cells, you get all of these side effects. So they said, how about we just create the linker in the lab and let the body culture the T cells in response to this connection, and maybe we will get less side effects with the same efficacy. So, and these agents, you can see that we don't have a lot of data, but we already have data from around 300 patients treated on these treatments. And you can see that around 40% of the patients will have long-term remissions. And more importantly, those patients who get to a complete remission, around 75% of them will really have long-term remission, which is very similar to what we saw across the board: CAR T cell, high-dose chemotherapy with stem cell support. If you get a complete remission, at least 75% or 2/3 will maintain these complete remissions, and therefore that's why we always aim to get a complete remission with treatments of diffuse large B-cell lymphoma. And how about side effects? So as we hypothesized, the side effects are much lower, and you can see grade 3/4 cytokine release, which is this flu-like phenomenon that happens in only about 4%, which is much lower than what we see with CAR T cells. And you can see that severe ICANS, which is the neurological events, in only 2.5%, which is also lower than we see with most CAR T cell products. So these agents have an easier toxicity profile, but on the other hand, they are given for 12 months or sometimes even until progression. So that, CAR T is a single event. It's a one-time treatment. So it may take you a month, or it may be a little bit harsh, but you're done. While here with these treatments, you have to come in first every week, then every 3 to 4 weeks. So it takes a long time. The second thing that I wanted to show you, which I think is really, really important and encouraging, is that the response rates, the complete response rate after CAR T cell therapy, so someone has failed CAR T cell therapy, the response rate for prior CAR T cell therapy are as good almost as good as those that didn't receive CAR T cell therapy. Meaning that being resistant to CAR T cell therapy doesn't mean you're going to be resistant to these novel agents, or these novel agents can still work for you. This is a coritamab. It's another drug given initially every week for 3 months, then every other week for another 5 months, and then every month until progression, so forever, even though we are starting to make these treatments no longer than a year. And really, another interesting thing that you can see about these treatments, that by 6 weeks, most of the CRs have happened, and all of the patients who are bound to get a CR have had a partial remission by 6 weeks. By 12 weeks, nearly everyone who is supposed to have a CR had a CR, meaning that within 3 months, you really know whether this treatment is working for you or not. And again, you can see that patients who had prior CAR T cell therapy responded and progressed, or were refractory to the prior CAR T cell therapy, still have excellent complete responses to this treatment. So this treatment works also for people who have failed CAR T cell therapy, and we can expect it to be the other way around as well. So when you're thinking about your treatment, you will start with RCHOP, RCHOP-like, We really want to find out as early as possible whether you're resistant or not, hopefully within 2 to 4 cycles. Then you can either go to CAR T or to a bispecific treatment. These bispecifics have been submitted to the FDA, but yet to be approved for diffuse large B-cell lymphoma, probably within the next few weeks. But even if not, remember that you can have them on clinical trials. And all of these patients here, and all of the patients we talked about before, these are patients that understood that clinical trials in many cases would offer you the treatment of tomorrow today and have benefited tremendously, right? Remember, these are patients who have, many of them have already failed CAR T-cell therapy. They didn't have a good option for them. And so you have this as your other option. And then for the few people who remain afterwards, we have multitude of other options as we discussed. And last thing about clinical trials is, you know, if CAR T is FDA approved, or if you're in Europe and it's approved by EMA or your local authority, and there's currently a clinical trial with a treatment that is very promising, you may want to keep the joker in your pocket because it's only 40%, right? And go here, try to get another 40% upfront, you know, from something that may not be available for you if you go on the CAR T-cell route first. So that's it for today.